Welcome back to another episode of The Learning Curve, the podcast where we explore bold ideas and reimagine the way we teach and practice medicine. My name is Irtaza Asar, and today we're going to be diving into a topic that's quietly reshaping how we care for patients in some of their most critical moments: trauma-informed care. Emergency medicine is fast, it's intense, and it's often chaotic. But behind every patient encounter is a story, and sometimes this story includes trauma, like childhood adversity, violence, systemic injustice, and these often walk into our exam rooms right alongside our patients. So how do we meet patients where they are? Not just clinically, but also emotionally in these moments. How do we recognize when behaviors that frequently get labeled as difficult are actually signs of distress? And how do we respond with care instead of control? In this episode, we'll explore how trauma-informed care is not just about slowing down or being soft. It's about being smart, compassionate, and effective. Joining me today is an expert, Dr. Taylor Brown, and she is part of the Harvard Medical Faculty Physicians at Beth Israel Deaconess Medical Center. And today she's going to share her incredible knowledge on the principles and challenges and power of trauma-informed care in the ED. Taylor, thank you so much for joining me today. I really appreciate your time.
I'm so excited to be here. What a beautiful introduction.
Thank you so much. I like to hype everybody up. If I had like pyro or even better like editing skills, I think that would really add it on. One of the things that I've done with every single guest, and we're going to do this with you as well, is what is a hidden skill that nobody knows that we can chat about just for a few moments, Taylor?
I memorize song lyrics incredibly quickly, and they stay with me for decades. So if you ride in the car with me or you're around and I have music on, you'll be subjected to one of my acoustic hours because I just can't not sing along. And so sometimes my family will like put songs on and try to trick me, and I don't know. I don't know where the little, collection of neurons is that stores all that, but it's like thousands of songs.
That is so cool. So if you're ever on like a Jeopardy category for like song lyrics, I already know who I'm putting my money on. So this is great. And anybody at a conference, if you ever need somebody to recite random songs, Taylor's your person to go to. So now that we have that hidden skill out there and everybody knows, I think this is a great segue into trauma-informed care. So to set the stage for this conversation, Taylor, can you talk to me about what exactly is trauma-informed care and what are its core principles?
Sure. So usually when I talk to ER audiences, I always have to make sure, we're not talking about blunt and penetrating trauma. That is a type of trauma that people can experience, but we're thinking a little bit more broadly. Any kind of event, series, or set of circumstances that someone experiences as harmful or threatening in some way, and then that experience has some lasting impact on them. And when we think about trauma that broadly, there's so many experiences that could impact our patients. So then trauma-informed care is actually this harm reduction framework that was developed by a government body, actually, Substance Abuse and Mental Health Services Administration, or SAMHSA. Back in the 90s, they were working with women who had comorbid substance use disorder and had survived IPV. And they came up with this framework. And really what it does is it recognizes the widespread nature of trauma, how many people have had these experiences of adversity, and then it actively seeks to avoid re-traumatizing them when they interact with healthcare.
Awesome. And I think that's actually a fantastic definition. The backstory to actually this episode was I remember I met you at the ASAP Teaching Fellowship, and one of the first things that you had talked to me about was the gospel of trauma-informed care, and you had framed it as gospel.
Yep.
And afterwards, when I went back and I was looking into it, and I was like, this is a topic that I don't think a lot of educators and residents, medical students get a lot of formalized education on. And this was definitely one of the reasons why I wanted to get you on early on. So from your standpoint, what are the key principles of trauma-informed care with regards to emergency medicine?
SAMHSA has 6 principles that they developed through working with this patient population and their qualitative interviewing. And the 6 principles come down to safety. So ensuring that patients are both physically safe and psychologically safe. Trust and transparency. So how are we building that rapport with our patients? How are we providing anticipatory guidance so they know what's coming in their care? Empowerment, voice, and choice is probably one of my favorites. So as we're able, kind of within the confines of emergency care, how are we giving power back to patients and allowing them to have some choice in their care? Collaboration too, again, working with patients, partnering with their families sometimes as well. Peer support, how are we able to, in emergency settings, allow people to have someone there Sometimes that's even as simple as allowing them to call that family member and have them on the phone when you're giving the updates. And then finally, cultural awareness. How are we recognizing the diverse experiences of trauma and then the intersectional nature of adversity as well?
And I think that really helps to establish a framework that we can continue to segue this conversation with. So let's shift gears. How does that differ from traditional emergency care that we typically provide on a shift to shift basis?
So I think there's a lot of people out there who are doing excellent patient-centered care, but it's not always trauma-informed. So the real paradigm shift is, instead of asking a patient, "What's wrong with you?" we're instead thinking, "What has happened to you and how has that impacted you?" So for example, for folks with, substance use disorder, that's, instead of focusing on the substance use disorder, we're trying to think about, why are they using? What pain is the substance kind of covering up or treating for them? We do the initial medical stabilization, but it helps us to just get one layer deeper to understand why patients have ended up at our doors and what impact those experiences are having on them.
Interestingly enough, I think after I started reading more about trauma informed care after the ASAP teaching fellowship and meeting you, I actually had an interesting patient encounter a couple of weeks ago with one of my residents where the plan was to admit this patient for respiratory failure. She had pneumonia, elderly female, and my resident came out and said, "Hey, she basically doesn't want to stay here and she wants to go home." And I was looking at him and I'm like, I think that'd be a hard sell. She's already on OptiFlow and we're at a point where we probably have to bring her in to get her situated. So I went back in and I asked her, and I said, "Hey, what's your hesitation with coming in? Is something bothering you that I can help you with?" And she went into this story about how her husband had COVID a long time ago. And this was during the time where visitors were restricted from coming into the emergency department. And she had said that she never got a chance to talk to him. He ended up on a ventilator and then eventually, subsequently, ended up passing away. And she was dealing with the trauma of that. And from her standpoint, her fear was, hey, what if I get admitted? I end up on a ventilator. I end up in a situation like that. I don't want to be in that situation. That's my fear. That's my worry. And just hearing that story, it clicked a lot of light bulbs in my head, and I brought my resident back and we sat down, had a conversation with her, talked to her about the next steps, and kind of eased her mind about a lot of the anxiety that she had with some of her past experiences. But I think that's actually a really great segue into the next question that I wanted to ask you about. Is we talked about what trauma informed care is, we talked about some of its core principles, but let's talk about the impact that trauma has on patients that come into the emergency department. Can you talk to me more about that?
When I teach this subject, I kind of teach it in two arms. I think about both the impact that trauma has on a patient's health and then the impact that trauma has on a patient's health-seeking behaviors. So to start with the impacts on health, kind of the whole field uses the Adverse Childhood Experience Study, or ACEs, and that's kind of our foundational understanding of how, in this case, early childhood trauma impacts health as an adult. And that was, again, back in the 90s through Kaiser Permanente. And this was in a privileged population. The majority of patients were white, they were middle class, they're insured since it's through Kaiser Permanente. Even in that population, a majority of adults, 51%, had experienced some early childhood adversity. And then they found a dose-dependent relationship. In their highest risk category, adults with 4 or more ACEs, compared to adults who had experienced no adversity, 12 times higher risk of attempting suicide. They have a greatly increased risk of having substance use and alcohol use disorder. It's not just alcohol and mental health. There are real impacts on all the organ systems. So they have a higher likelihood of developing certain types of cancer, as well as they're twice as likely to have cardiovascular disease. So I think that study really helps us to quantify how trauma and adversity is impacting our patients' health. But the other side of that really is, how does it impact how people seek care? And we're starting to understand this. There's a couple studies of, in the emergency department setting, folks who come in as a result of community violence. So we're thinking gunshot wounds, stab wounds, being assaulted in the community. And in some of the violence intervention programs, they surveyed those survivors, and 100% of them had experienced early childhood adversity. There's also studies from traditionally marginalized populations, such as up in Canada, they did a study of individuals who identified as transgender seeking emergency care. And about a quarter of them reported delaying seeking emergency care, even when they really thought they had an emergency condition, because they were worried about experiences of discrimination. So that's showing us, it affects our patients' health. It affects how they present to the emergency department. It affects maybe they avoid seeking emergency care for fear of discrimination. And then finally, if they do get to our door and interact with us, it can affect how they interact and behave in the healthcare system. So I think one of the most impactful teachings in trauma-informed care for me was understanding that when people have been under threat for a long time, maybe they had a childhood where they were constantly on guard, constantly in that fight or flight, they can be really reactive. But if you take a trauma-informed lens to that, they learned those skills in an environment where that was protective. That was a survival skill. So at one point, it really served them. But then when you take it out of that context and now they're in what we consider to be a relatively safe environment in a healthcare setting, that reactivity, flying off the handle at what we think is something very minor seems to us to be really disruptive. It's a difficult patient, but really it's just a maladaptive survival skill.
Absolutely. And I think that's a great framework from which I think we can understand some of these situations that we find ourselves in. I can think of countless case examples where quite often, nurses will come up to you, young learners will come up to you and be like, hey, man, this guy's being really difficult, or she's being very difficult with this. I don't know why. And I think just taking the step back and trying to apply that trauma-informed lens, and I really love that phrase that you used there, which I'm going to shamelessly steal and apply that with all my learners, I think can really help us navigate some of these situations. So can you give me some cases or some scenarios where we can see situations where we can apply trauma-informed lenses?
I think you brought up a leaving AMA example, and I think AMA discharges are just, ripe for a trauma-informed lens and trauma-informed interventions. I've had patients for whom it's needing to go outside and smoke a cigarette is the thing that, they're going to leave unless they can do it. And with all of these, it's, working with security staff, nursing staff, making sure everyone's on the same page and comfortable with the plan. But a lot of times it's people don't want to be admitted to the hospital because they've had previous negative experiences. I think about a patient I had who had pancreatitis and got a TAP block. And during that procedure, how they retell it, they were telling a provider to stop because they were in too much pain, and the provider didn't stop and continued to proceed with the procedure. And what they were describing to me was PTSD after a medical experience. They had flashback, they had nightmares. And so they were continuing to suffer at home and not presenting to the emergency room. And then when they finally got to us because the pain was so severe, they were labeled as a difficult patient because they did not trust the medical system. And so when I talked to that patient, my immediate approach was trying to align with them on their care need, which was really pain. And so I said, tell me what works for you. Give me the names and doses of medications. This is an individual who has tried a lot of these. And even in the chaos of the emergency department, I said, I'm going to set a timer on my phone. And fortunately, they were in a hallway space, which made it easier to check back in. But I'm going to set a timer on my phone and swing by and see in 15 minutes if you need another dose of medication. So in that case, collaborating with the patient, empowering them to tell me what works for their pain, and then as much as I can, trying to give some anticipatory guidance that they will see me again to check in on their pain.
Absolutely. And I think that's a fantastic case example of a situation where we can really apply that trauma-informed lens and make this more of a collaborative approach, and also allow our patients to not only have their autonomy, but also allow them to build trust with regards to the medical system, especially in cases like the one that you just brought up, where it's very, very easy to become jaded and dissuaded and just not trust any medical provider that you see moving forward. So having said that, what can we do as physicians to basically create safe environments in our emergency department? What are some tips and strategies that we can employ that you would recommend?
So I'll get into the practical points in just a moment, but I do want to say that trauma-informed care is a universal precaution that we can use with every patient, because there's no way for us to tell who has had these experiences of adversity. Sometimes it's obvious. They present to the ER having just experienced something that we may label as traumatic, but oftentimes we don't know. So these are things that I use with every patient. So there's some really concrete things. I already mentioned anticipatory guidance. I think a lot of fear and traumatic experiences in the ER surround the lack of control and not knowing what's coming next. So I'm extremely explicit with my patients where I can be about what the plan is, the steps, how many times they will see me as the doctor, and being very explicit about wait times. If they are going to board in a hallway bed for 24 hours prior to admission, I tell them that up front. And I think sometimes we underestimate, we don't want to upset people, but I think we also underestimate their ability to cope when they have the information available. Another practical tip is I offer choices and control when I can. Sometimes that's as simple as, do you want the door open or closed when I leave? Lights on or off? Would you like another blanket? I think about this a lot of times with procedures. For example, if I have to do a pelvic exam in the emergency department, I inquire about previous experiences with that procedure. I ask people if there's no one with them, do you want to call someone so that someone's here with you in the room to talk through it? Would you like to listen to music? Would you like me to narrate every part of the procedure, or you just want me to get it done? Those are all ways in which I'm offering control back within the constraints of what I have in the emergency department. I'm not offering someone a private room with a TV and a hot dinner. It's probably still going to be a soggy turkey sandwich. But again, working with what I have to try and draw patients in and collaborate with them.
Those are all actually great examples of ways that we can create a safe environment in the emergency department. I know specifically with a lot of my younger learners, it was just assumed that, hey, you know how to do pelvic exams, you know how to do sensitive exams, so I expect you to just go do it. But then when I became an attending, one of the first things I did was whenever I would have younger learners, I would say, hey, listen, let's go do this together and let's have an actual framework from how we're going to have this conversation. Because yes, I know you probably know how to do a pelvic exam, but I just want to make sure that you have a conversation specifically with regards to how to do this sensitive exam, because you don't know if this individual has ever had one or if there's any concern about sexual violence in the past or any related trauma. And I want to be able to have a proper conversation with them to set the stage for what we're about to go do so that they're comfortable and also you're comfortable as well. So I think that's actually a really cool example of ways that we can really create a safe environment in the emergency department. Are there certain tips and strategies that you have with regards to communication and language choices that can also help us?
Some of the ones I think about right off the bat are ensuring that when we're talking to patients, we're using their preferred name, their correct pronouns, their correct anatomical terms. Some places are fortunate enough that this is integrated really well into the EMR. So usually when I address patients, I ask for their last name to confirm identity and then ask how they would like to be called. I have a badge that says my pronouns, so it kind of invites that conversation as well. And then anytime that I have a patient that is maybe non-binary or gender diverse, if I have to talk about particularly sensitive organs, then I always ask permission to say, are you okay if I use medical terms, or do you have other terms that you use? Up there with language, I would say avoiding stigmatizing language. So we've already mentioned a couple times the trope of the difficult patient. Other terms in here, I think about terms like addicts. The only time I would use a term that's potentially stigmatizing is if it's a term that the patient is using to describe their self and you're kind of mirroring their language. But otherwise, I prefer centering person first language. So instead of a diabetic or an alcoholic, I'm using terms like a person with diabetes, a person with alcohol use disorder, an individual experiencing homelessness.
Those are actually really great points. Now that we've established that, specifically techniques that we can use to create safe environments and also language and communication choices to apply that trauma-informed lens, I want to talk about some of the challenges and barriers that we have with regards to applying principles of trauma-informed care. And I think your example before, you touched on it a little bit about, the hallway situation, that the system barriers are always there.
Yeah.
I don't know if there's any emergency department out there that isn't dealing with system issues like boarding and hallway spaces and waiting room medicine issues. If there isn't an ER out there, I wish they would let me know so that we can apply their principles to our ER. But I think those are some common problems that probably every single emergency department across the country is facing. So having said that, what are some things that we can do to possibly still practice trauma-informed care despite some of those barriers that we have?
So kind of among the folks that I practice with who are experts in trauma-informed care, I'm one of few individuals who went into emergency medicine. I think a lot of this was originally developed in mind for folks that practice in outpatient settings. They maybe have a little bit more time and maybe more longitudinal relationships. But I think the emergency department needs this intervention as much or even more so than some of those other settings. So we talked time constraints. The ED is fast-paced, it's unpredictable. Sometimes you're pulled away from a patient in the middle of a conversation. Maybe they're disclosing something traumatic that happened to them, and you get the code stroke alert and you have to run away. So that's a challenge. Privacy is an extreme challenge in the emergency department. We have hallway spaces. In my ER, we go out and see folks in the waiting room. And that's a challenge both in privacy of discussing with patients, but also, if they need an EKG in the hallway, not all patients are comfortable kind of moving clothes around and exposing themselves. There's extremely long wait times to see a provider, and it's so unpredictable. I can never tell you exactly when your exam or procedure or CAT scan is going to happen. And I think all of those systemic barriers too are facing so much burnout. And although we'll get into it later, I think trauma-informed care is an excellent kind of antidote to some of the burnout and moral injury we experience. There are certainly shifts where I felt not my best trauma-informed self because I am exhausted and so overwhelmed by just the state of emergency medicine.
Absolutely. If you create some goalposts and signal posts for patients that, hey, listen, you might be in this room for a while, or you might be in our waiting room for a while. And I think that's one way that I've found that sometimes can help to navigate some of these issues. And I tell folks, and I apologize up front, hey, listen, I don't really have the space to get you into a room, but I will try my best. In the meantime, what can I do to help you in the best way that I can today, given the situation that we're in? And I think that helps. One of the things that I wanted to talk to you about is, from a provider standpoint, what are some challenges that we can face as providers that potentially impact us from a trauma-informed care? I know we were planning on doing that later, but I feel like now it might be a good time because you kind of set the stage for this conversation. And I think this is probably one of the most important takeaways from this episode. So what are your thoughts on that? And what are some of the challenges that we face as providers with regards to applying this?
So I think after the pandemic, it has become much easier to have a conversation about how our job as emergency medicine providers can be traumatic. I don't think anyone now pushes back on the idea that we can experience secondary trauma and vicarious trauma through work. The pandemic is one, but we see things all the time that are really challenging. And actually acknowledging that the work affects us is something that maybe previously to the pandemic was something that I actually had to teach and get folks to actually reflect on. The other thing is that we've been saying, patients this, patients that, patients have these experiences of adversity. So do providers. We are included in those statistics. And so when we're seeing a patient with substance use disorder, or we hear someone speak maybe pejoratively about someone with some of these stigmatized conditions, there's a very high likelihood that your resident, your colleague, one of the nurses, if they haven't experienced it themselves or survived it personally, someone close to them has. So I think everything that we're talking about in terms of providing trauma-informed care for patients, all of those principles can be applied so broadly. So a lot of the other work that I do is taking those principles and actually applying it to our learning environments.
That's a great point. What I try to tell a lot of my learners is that this is probably the one field where you're going to see things that no other field will ever see. Yeah. So things like sexual violence, child abuse, just workplace violence, substance abuse, all these issues that you see, a lot of fields don't necessarily get to take a role in terms of patient care. And we see that, and all these things can definitely cause moral injury to us as well as clinicians. And I think that can impact how we respond to patients as well. So I think having this framework in mind can really help us navigate a lot of these difficult circumstances that, we can face on a shift-to-shift basis, and really help deal with some of the moral injury issues that inevitably will happen in emergency medicine, just given the nature of what we do on a daily basis. Let's say if I'm your medical director and you come to me, you talk about trauma-informed care. I have some misconceptions. Let me give you a misconception, and I'll have you challenge me on that and show me the light and the gospel of trauma-informed care. So I tell you, Taylor, we don't have time for this in the ED. How would you respond to that?
I would say that, everything that I've proposed so far is a very small shift within a clinical interaction that should not extend the time or have any throughput impact. I would also say that there's a real opportunity for patients that we have traditionally had difficulty caring with and are traditionally difficult patients, that potentially a trauma-informed approach to this could actually expedite their care. If it's someone who has a lot of difficulty tolerating a procedure, for example, maybe someone with IVDU who needs an abscess drained, but they've got that hyperesthesia, they have trouble with pain tolerance, but you're able to work with them in a trauma-informed way, you may be able to get that procedure done much faster than you would in a more traditional approach to that patient.
Absolutely. You've convinced me. All right. One more misconception. So, your medical director tells you, Taylor, I'm not a therapist. This doesn't really make sense to me. How do you tackle that misconception and how do you address that resistance?
I'm also not a therapist. I do not provide trauma-focused care and trauma-focused therapy, which is an entirely different field that folks get specialized training in. Trauma-informed care is a universal precaution to help try to prevent re-traumatization. When patients disclose trauma to me, I'm not trained in how to unpack that and figure out exactly how that's impacted them. And the ER is usually not a safe place to get into that and unpack that. So usually I'm meeting that kind of disclosure with something like, thank you for trusting me enough to share that with me. It'll help me best care for you, but we don't have to go into all the details right now.
Excellent. I think you've addressed that misconception as well. And I'd love that. So, as we're getting low on time, I want to ask you what are some practical steps that we can take as clinicians to improve our ability to practice trauma informed care?
So I think, framing your interactions with every patient in a trauma-informed lens. Whenever you're met with those behaviors that make you just want to pull your hair out, pausing and thinking, why? Where is this coming from? For me, that has helped a lot with those interactions that would normally drain me. We talked about a few practical things such as offering choice where you can, offering peer support when you're able to, offering modifications to a physical exam, providing anticipatory guidance. Those are all small things in each clinical interaction that are practical steps for implementing trauma-informed care. When I think about more of an institutional or a programmatic level, there's plenty of ways to implement trauma-informed care, whether it's educational modules or workshops for your residents, which we've developed some and I'm happy to share in the show notes as well. So there's actually ways to look at trauma-informed care within your policies. So folks over in the Mass General Brigham system did a big QI intervention where they trained staff, all levels of staff, in trauma-informed care for their behavioral health responses, and they were able to decrease the total time that all patients spent in chemical and physical restraints, and they were actually able to make real progress on racial disparities in restraint use in their emergency department. So those are some of the ways that I think about trauma-informed care more at a programmatic and then even institutional level. Finally, trauma-informed care for self. For myself, engaging in this work has been a way to combat the burnout and moral injury that we face in emergency medicine. I think it's a great way to structure supporting your peers. Again, all these 6 principles that we talk about, they can be applied to how we're creating a learning environment for our residents. It can be applied to how we're thinking about, burnout prevention programming for our colleagues. So I think the 6 principles are so broadly applicable.
Those are some amazing tips that really can help any clinician at any level of their training to practice trauma informed care. And like you said, I think from a patient-centered standpoint, I think there's a lot of great benefits that can really help in difficult situations that we encounter on a daily basis. And just from a physician standpoint, there's so many benefits to this, especially with regards to a lot of the challenging and difficult situations that we find ourselves in that we take after shift, take it home, and that can cause us moral injury and contribute to burnout as well. So those are some incredible tips there. So one of the things, Taylor, that I do with every single guest towards the end of the episode is I ask them, hey, if I'm a first-time listener, what are the 3 key big takeaways that I can take away from this episode?
The key takeaways I would hope someone would remember after listening to our episode would be, firstly, that experiences of trauma and adversity are so incredibly common in our patients and ourselves, and they can have really profound impacts on patient health and also how they interact with healthcare. The second would be that trauma-informed care is a universal precaution. These are skills we can use with all of our patients because we never know exactly what they've experienced and what may trigger some kind of reaction for them. Finally, I'd remind folks that TIC is a powerful tool that we can use with ourselves and our colleagues to reduce moral injury and hopefully push back on burnout within emergency medicine.
I think those are fantastic takeaways. And for any first time listener, I think those are three really, really key valuable points that can really help take their ability to communicate with patients and also their ability to understand patients just to a whole nother level. So Taylor, thank you so much for those incredible takeaways. Are there any resources out there that you would recommend for somebody that's just newly learning about trauma-informed care that they can go back and reference to? And I'll include those in the show notes as well.
Yeah, I'll include a couple of kind of the foundational papers about what trauma-informed care is, and then we've developed some. They're predominantly focused at medical students, but I think if you're first introduced to trauma-informed care, some resources on trauma-informed care communication, physical exam skills, and then trauma-informed approaches to procedures will be coming out over the summer. So maybe I'll have to send you updated show notes. Finally, there's a group that I'm a part of, the Trauma Informed Healthcare Education Research Collaborative, or TISER. We can include that link as well, but that's a national collaborative of physicians and other health allied professionals across the country working to implement trauma informed care.
That's perfect. And I'll include the things that you forward me to the show notes as well so folks can reference those. Do you have any last minute thoughts? Anything else that you wanted to talk about with regards to the gospel of trauma informed care? You've definitely
I was
converted
just
me.
going to make a gospel joke.
You've definitely converted me. So,
And I mean, it's my final thought I want to leave
yeah,
everyone with. I think, sometimes people are surprised that I do so much trauma work and they think, isn't that so depressing? But I think when we think about trauma, we think about PTSD, not everyone has that experience. And the flip side is that patients, your colleagues, like people can grow and heal from these experiences too. So you can also experience vicarious healing. And I think it's those moments where even in an ER interaction, you're able to see how you maybe move someone from complete mistrust to have a little bit of trust in the healthcare system that is just so fulfilling, and that fights my burnout.
absolutely. And going back to that case that I referenced, one of the things that I've gotten in the habit of is I always ask my residents, hey, what was the most memorable case of the shift? And that was the one case that we had practiced trauma-informed care. And the resident had looked at me and said, you know what, we did a lot of, procedures today. We did a lot of interventions, but helping that lady out in that really vulnerable moment, I think was probably the most valuable thing that I'm going to be taking away from this shift. That was one of those like light bulb moments that I was like, you know what, this makes sense. And I really have to try to get better as an educator to be able to communicate some of the principles of trauma-informed care. So that was fantastic. Hey, thank you so much for joining me today. This was definitely one of the best episodes, topic that really, if we can get the word out even more about, I think we can help countless educators and folks that are just starting their patient interaction experiences. So I think it's really, really valuable. Taylor, is there any place on social media where folks can reach out to you and talk to you about trauma-informed care?
Probably my professional email is the best way to reach out
Okay.
to me, or through the TISER group.
Okay, sounds good. Perfect. Well, thank you so much for joining me. This was, again, a fantastic episode. For all the listeners out there, tell us, what have you done with regards to trauma-informed care, and how have you applied those principles to help your learners? What kind of strategies have you employed? What kind of simulation cases are you guys using? Let us know. Let's keep the conversation going, because I think, again, this is something very valuable to teach our young learners out there. So thank you so much for joining me. Follow us on Apple and Spotify, like us on YouTube. See you guys soon for the next episode.